So shall we start?
Yes, please.
Yeah, okay. Hello everyone, we welcome you to this online session, which is a part of the entire comprehensive 25th MRI teaching course. As you all know, this is the 25th year of this academic fiesta, and this is a truly academic event. This year it is bigger and much better, I would say. So we have divided into online sessions, which started on 12th of April. We had a full day online session on 12th of April with national speakers. Yesterday we had team from Mayo Clinic and we went through all the basics as well as advanced neuro topics with the experts. Today morning we had sessions from Rush University experts, and now we are delighted and looking forward to this session where we have expert speakers from Sick Kids, Toronto. And all thanks to Dr. Manu Shroff, Dr. Manohar Shroff sir, as we know him all. Because of him, we could actually connect with these great lineup of speakers, and we will go through these topics, which will include not only the basics and advances, but also their expert comments. And I would also encourage that if you have any doubts or you want any clarification or anything to discuss, you can please put that in the chat box, because all our speakers will be online during the event and they would be happy to answer. For this, I would again like to thank them because they took out time and they are here online. It's not that only recorded sessions are there. They are with us during the entire 2 hours duration. So this would start with these 4 topics, as you can see on the screen. And then we will have a pre-conference workshop, which will be on 23rd of April. That day, we'll have a full 9 a.m. onwards till 7 p.m., a full day on-site workshop where we're going to learn a lot about advanced MR imaging topics, step-by-step case-based approach, including breast imaging, cardiac MR, MRI in rectal malignancies, MRI in prostatic malignancies. Registrations are still on for the workshop as well as the main event. So all of you today who are listening to these lectures can spread the word around that if they still want to register, they can register for the event. And then the main event would start on 24th of April. And that will be for 3 days. The first day, neuroradiology, second day, MSK imaging, and third day would be body imaging topics. Now, without further ado, I would like to start the day today. And the first speaker for today, as well as the person behind this entire online event from Sick Kids, Dr. Manu Shroff sir. Sir is a pediatric neuroradiologist at the Hospital for Sick Children, Sick Kids, professor of radiology at University of Toronto, former radiologist in chief, Sick Kids. He's certificate of added qualification in neuroradiology from the ABR. He's also the founder member for neuroradiology subspecialty at RCPSC, past board member for American Society of Pediatric Neuroradiology, ASPNR as we know, and his key area of interest, clinical and research focus is neonatal imaging, pediatric stroke, and neuroinflammatory disorders. He has over 200 peer-reviewed publications, and he has received multiple excellence in teaching awards. So we all know him very well, and he has been mentor to many of successful radiologists all over the globe. Thank you, sir, once again for joining us, and over to you.
Thank you so much, Mitusha.
Dear delegates, this is Dr. Manohar Shroff from the Hospital for Sick Children in Toronto. Welcome to the Silver Jubilee, 25 years of this highly regarded MRI teaching course. Compliments to Dr. Deepak Patkar and his team. Today, my colleagues Dr. Govind Chavan, Dr. Vivek Pai, and Dr. Caroline Rattan, all highly talented and skilled pediatric radiologists, will present on advances in MRI techniques and sequences, cortical malformations, and pediatric emergency cases. And I shall be presenting on pediatric head and neck imaging top 10 things to know. We are very grateful to Dr. Patkar for giving us the honor to present in this prestigious teaching course. So let's start. No disclosures, no conflicts. This is my hospital in Toronto. It's a fantastic hospital and it's a real privilege and pleasure to work in this hospital. To begin with, a quick overview. Most head and neck lesions in childhood are congenital or inflammatory, but we do need to make sure that we do not miss the occasional malignant lesion. We image to characterize lesions and to see their extent, and these are the techniques that we use: ultrasound, CT, or MRI. Our objectives will be to review examples of 10 important categories of lesions, from normal variations, emergencies, vascular malformations, brachial anomalies to malignancies. And in the end, maybe some unusual lesions and bonus cases. Let's start with this normal variation. Note that there is lack of ossification in infants and toddlers in the skull base. Do not mistake this for an encephalocele. Ossification begins laterally and extends medially. And you can see in an older child there's complete ossification over here. Enlarged reactive lymph nodes are very common in children. Even reactive retropharyngeal lymph nodes can be commonly seen. If you were to see retropharyngeal enlarged lymph nodes in an adult, you would worry about a malignancy in that region. And of course, if you have large abnormal lymph nodes like this, then you have to worry this was due to a lymphoma. This 6-month-old with trauma had prevertebral soft tissue swelling on the lateral view, and you can see this very nicely. CT scan was done within 30 minutes, showed completely normal prevertebral soft tissues. And this is often seen in a young child performing a Valsalva, and is due to laxity of soft tissues and engorgement of vessels and veins. Note how the unossified anterior arch of C1 and the unossified odontoid is a normal variation over here. And you can beautifully see all the ligaments, the tectorial ligaments, the apical ligament, atlanto-occipital ligament, very nicely. Just to show you a better view of the ligaments and the unossified anterior arch and the odontoid tip. We come to our next topic, epithelial inclusion cysts. These include epidermoids, dermoids, and teratomas, depending on the cyst lining. For example, a teratoma will have all 3 layers, ectoderm, mesoderm, and endoderm. The lateral aspect of the orbit is a very common location for small dermoids, and you can see a small, nice fat density lesion over here. Let's look at this coronal temporal bone images. We see a non-dependent soft tissue mass medial to the ossicles. And you can see the Prusak space over here is free. The mastoid air cells appear to be normally aerated. There's no sclerosis. And this is actually a congenital cholestoma. Cholestoma is a misnomer. Actually, these are epidermoids, so the correct term for them is congenital epidermoids. And this is just to show you what a normal Prusak space looks like, lateral to the malleus head and medial to the scutum. Now, cholesteromas or congenital epidermoids can occur anywhere, and here is one in the left mastoid. They can be diffusion restricted. They may not be truly diffusion restricted. The ECG maps may show T2 shine through, but they look dirty, hypointense on T1 without enhancement. They do not show any internal enhancement. On T2s also they're hyperintense, and on flare they have a dirty, hyperintense appearance. So this is a classic appearance of an epidermoid. Another common location for epithelial inclusion cysts is the root of the nose. During normal development, the dura projects out through a small dural stalk and touches the skin, and then with development that sort of regresses completely. When there's any of those elements of that fistula which do not regress, then you have epithelial rest within, and you can get dermoids and epidermoids along this tract. So just to show you a small dermoid at the root of the nose, going up through a fatty tract through the nasal septum up to the foramen cecum. And you can see the same case, the foramen cecum is pretty widened, it's bifid over here. That's a very good sign of intracranial extension of a nasal dermoid, a nasal sinus with a dermoid. This is a small dermoid, well, more than just small, with a sinus tract going up through the root of the nose to the nasal septum into the crista galli, which was bifid. This is a very interesting case, presented to us on emergency with signs and symptoms of meningitis. Showed a small diffusion-restricted lesion in the basifrontal area with edema. It showed enhancement which was extending up to the crista galli and root of the nose, and this turned out to be actually a nasal dermoid with a sinus extending up into the root of the nose and the crista galli. And actually, we call this as an abscess, but at surgery, this turned out to be an epidermoid which had ruptured and caused a chemical meningitis. So everything that is diffusion restricted is not an abscess. Remember, epidermoids can be diffusion restricted also. So just quickly to summarize, if you see a midline nasal mass, this will be a differential diagnosis, and this is more for the residents. Dermoid sinus, epidermoid cyst, encephaloceles, hemangiomas can occur over here, dacryocystoceles, and sometimes the rare nasal glial heterotopia. This is a confirmed nasal glial heterotopia with a small dural stroke going into the intracranial cavity. And now when you want to report these, you have to look for the extent and related tracts, intracranial connections, any evidence of infection or inflammation. Many of these can occur with associated craniofacial abnormalities or intracranial abnormalities, so please do look for those. This is to show you another epithelial inclusion cyst, the classic nasopharyngeal hairy dermoid or the hairy polyp. For some reason, when dermoids occur in the nasopharyngeal region, they contain more hair, and then they're called nasopharyngeal hairy polyps. And you can see this lesion very well, composed of different tissue densities. Another classic appearance for a dermoid, and this is known as a sac of marbles. This is sort of a pathognomic appearance at the floor of the oral cavity, and you can see these are loculi of fat with septa around, which look like a sac of marbles. So the floor of the mouth is also a good location for epidermoids, and you can see that the different densities over here. This was an epidermoid, a little less dense. This was pure fatty attenuation values, and this was a classic dermoid. Now when you do see epidermoids and dermoids in the floor of the mouth, make sure that you try to look for whether it's below the mylohyoid or not. This one is above the mylohyoid, because if it is below the mylohyoid, then the excision is from outside, surgical approach is from outside. Whereas if it is above the mylohyoid, the surgical approach is from inside the mouth. This is a large epithelial inclusion cyst seen in the neck. I just wanted to show this clinical image. When you have this image, 99% of the times, there are only two diagnoses at birth. One is that it is either a large teratoma or it is a large lymphatic malformation in a trisomy 21. In this case, it was a large teratoma. You can see the different tissue elements over here, a very heterogeneous mass. And this is another case, not the same case, but you can see calcifications, and you can even see a tooth-like density within this large neck mass. We come to our next sort of topic, that is cephaloceles, and this you can define by contents: meningocele, meningoencephalocele, or meningoencephalocystocele. In the Asian population, they often occur in the frontoethmoidal region, whereas in the Caucasian population, though much more rare, they occur in the occipital region. This is a classic appearance of a frontoethmoidal cephalocele. You can see the defect in the intracranial fossa in the midline, with an gliotic brain tissue herniating down into the nose. There's hypertelorism, and this is just to show a sagittal view of the herniation of brain contents through that cephalocele. We often do CTs and 3D CTs to sort of plan for surgical repair and reconstruction. And this is just a soft tissue reconstruction showing of what it looks like. Now make sure that when you look at these, also look for vessels. And I wanted to show you this case where the ACA was extending all the way down into this very large cephalocele. And if that knowledge is not known to the surgeon and they snip it off, that could be disaster. So it is our duty to look at if there's any large vessel extending into an encephalocele. This is a very rare presentation of a basal or a transsphenoidal cephalocele. Actually, this was a nasopharyngeal mass which was heterotopic brain tissue. So this was more like a heterotopia rather than a pure cephalocele. And you can make out that this was through a persistent craniopharyngeal canal, which you have to differentiate from the spheno-occipital synchondrosis, which is more posteriorly over here. We come to other types of seals, and that common one that we see in newborns is a dacryocystocele. The nasolacrimal duct at its inferior end has a Hasner's membrane, and when children are born, it usually perforates very fast, and our lacrimal fluid drains out through that. But sometimes in preterms, this does not perforate, and it obstructs and collects fluid, and you can get a dacryocystocele. If it gets infected, you get dacryocystitis. Treatment is very simple, as mentioned over here. And you can see these are bilateral enlargement of the nasolacrimal duct due to an unperforated Hasner's membrane. So these are bilateral dacryocystoceles. This is enlargement of the lacrimal sac over here due to obstruction inferiorly at the Hasner's membrane, so bilateral dacryocystoceles on MR. If they get infected, you can see this is a dacryocystocele with a fluid level and some streakiness around it and an irregular wall because of dacryocystitis. Okay, let's move to our next group of abnormalities, and that is vascular anomalies. Long back in 1982, Mulliken and Glowacki actually described a classification which for radiologists still works well, though this has completely changed in the clinical world. So you can get pure tumors, which are hemangiomas, which initially just after birth proliferate and then involute over the next 2-3 years. You get true malformations. The lymphatic and the venous malformations and the mixed veno-lymphatic malformations are much more common than the other ones. And of course, they can be associated with various other abnormalities. Now remember, I showed you this old classification because it suits imaging very well, but the new classifications are by the ISSVA, which keeps on getting updated every few years, and this also includes a lot of clinical things which we may not see on radiology. So infantile hemangiomas, most common head and neck tumor of infancy, presence very soon within birth, and short proliferation phase followed by a long involution. If your skin is fair and it's close to the skin, you'll see bright strawberry red discoloration. A classic appearance of a cervicofacial hemangioma involving the parotid gland. You can see how it's mildly bright on T2 with internal septations and flow wards, hypo-intense on T1, and intensely enhancing on contrast-enhanced images. It doesn't show any diffusion restriction. Now over time, in the next 2.5-3 years, this will involute. This is fatty change to the mass, and you can see how it's looking more like a fibrous fatty tissue. It can occur anywhere in the head and neck. This is one rare case of an orbital hemangioma. You can see this mass within the intraconal portion of the orbit, intensely enhancing like all hemangiomas. It's a soft tumor, so it's causing axial proptosis without indentation of the eye globe focally. And often they have an enlarged vessel supplying the tumor. So this is an enlarged ophthalmic artery. Our next group is lymphatic malformations. These are slow flow vascular malformations. They can be macrocystic most commonly. Microcystic are pretty rare, so we will not talk about them. Most of them are detected by 2 years of age because that is when the lymphatic system fully develops. And when they occur at birth or in utero, then they are associated with trisomy 21. This is a trisomy 21 associated large neck mass with fluid levels. Though lymphatic malformations don't have a lot of blood vessels, they can still bleed within themselves and cause fluid levels. This is a classic lymphatic malformation. just deep to the sternocleidomastoid, non-enhancing septated transspatial cystic mass. And this is the appearance of a classic lymphatic malformation in the neck on MRI. Thin septations, usually no enhancement. Occasional thin enhancement of the septae is allowed. Mixed venous and mixed lymphatic malformations are very common. When they are more venous, they are not apparent for years because the venous system keeps on growing with age. So often they might present at 12, 14 years of life. Compared to hemangiomas, they only have a bluish discoloration of the overlying skin. And let me show you a very classic example. This is a mixed intensity mass which is cystic. This cystic component is due to fluid and serous components which are very stagnant. Hypointense on T1. Solid peripheral enhancement is a venous component. The non-enhancing component is a lymphatic component. And then often they will have associated intracranial abnormalities like this DVA. Remember that venous malformations also have phleboliths, right? So the CT will show phleboliths, or on T2 you may see hypointense rounded areas within the lesion. Our fifth component of tumors is a thyroglossal duct cyst. This is due to cystic expansion of thyroglossal duct remnants. This is the most common congenital neck mass, and we see this incidentally very often when we do MR of the neck. Most of them present before age 10 if they are symptomatic. It's like a painless lump which moves with the tongue along with the hyoid bone. And you can see that the thyroid develops in the roof of the neck somewhere during embryology and then descends down through the thyroglossal duct. So this is a classic thyroglossal duct, usually central or to the left of the midline and very closely associated to the hyoid bone and the strap muscles. So a well-defined cyst, inseparable from strap muscles. It has this, there's a foramen cecum over here where there's a constriction as it goes down below and above it. And usually it is not enhanced unless it is infected. Then you'll see a thick rim enhancement and streakiness of surrounding fat. Our next component of the topic that we are going to show is branchial anomalies. So this is the first branchial anomaly. These are pretty rare. They are divided into type 1 and type 2. Type 2 are usually cysts in the parotid or parotid region. Type 1 are small sinuses or fistulae adjacent to the external auditory canal. Very often you'll see them in association with other craniofacial syndromes. So this is to show you a first branchial anomaly. You can see a little fistula/sinus very close to the EAC and the external ear. This is a small cyst with communicating with the floor of the external auditory canal, periparotid cyst. The second branchial anomalies are much more common. 90% of all branchial anomalies are the second ones, and the cyst is the most common type. Fistulas are very rare and sometimes very difficult to diagnose. So if you see a painless cyst at the just retromandibular in a young child, it's often a second branchial anomaly cyst. So this is what it looks like. Bailey's type 2, second branchial anomaly cyst. This is another MR appearance of the same. And then when they get infected, they'll have this thick rim enhancement and surrounding sort of granulation or streakiness of the fat, loss of fat planes. Remember that in an older person, if you see this appearance, then squamous metastatic lymph nodes can look exactly like this. So the correct context and correct age for diagnosis is very important. This is an interesting teaching case. If you have a child who presents recurrently with swelling of the left neck and involving the top of the thyroid, like in this case, the most important to do as a next study is to do a pharyngoscopy. And you'll see a punctum at the floor of this piriform sinus, which is diagnosis for a third branchial pouch sinus anomaly. When they're not infected, and if you just see this appearance, a small air bubble at the superior thyroid on the left side, that is pathognomic for a third branchial pouch sinus anomaly, but this is a very rare finding. So an important teaching point here is that cases of neck and thyroid infection in children, especially on the left side, should undergo direct pharyngoscopic examination to confirm the branchial cleft origin. Let's come to other lesions now, and this is just to show you how the thymus develops higher up and then goes down into the neck. So when you see a lesion like this, which looks like the thymus, smells like the thymus, and feels like the thymus, you can see that's what the thymus looks like. Do diagnose an ectopic thymus. These are touch-me-not lesions. You don't need to do anything about them. They'll regress with time. Now you see this occasionally on MR because sometimes people send them for MR directly. But the most common way of diagnosing this and almost confirmatory is ultrasound, where you have this small echoes over here like a starry sign, which is diagnostic, and you don't really need to do any ultrasounds or CT. Sorry, you don't really need to do any MRs or CTs in these cases. This is another touch-me-not lesion, the classic fibromatosis coli, where you can see spindle-shaped enlargement of the sternocleidomastoid muscle. And this appearance is very classic. Sometimes when you do an MR and CT, this can be very confusing and can look like an aggressive tumor. So if you have an ultrasound diagnosis, don't do an MR, it will only confuse you even more. So this occurs due to focal fibrosis of the sternocleidomastoid, secondary to maybe intrauterine malposition, breech position, and extraction. Over time they resolve, and ultrasound is diagnostic, remember that. This is a very interesting case, 7-year-old with 3-day history of left proptosis. Very vascular on ultrasound. In fact, in our department, some of us mistook this for a hemangioma, but that was wrong for 2 reasons. One is that the age was wrong. Secondly, there was diffusion restriction. So whenever you see diffusion restriction in a mass, always think of malignancy or tumor. And this did turn out to be a rhabdomyosarcoma. It was not a hemangioma or a vascular malformation. So rhabdomyosarcoma is the most common ones, embryonal, 60% of them. Whenever they are in and around the skull base, look for CNS involvement, look for any cranial nerve extension or extension into the brain cavity. It changes management completely. This is another classic tumor. I'm sure you know what all this is. You all know what this is. A 13-year-old with epistaxis and a very intensely enhancing mass which originates in the pterygopalatine fossa. The sphenopalatine foramen is medial to it. That's where it actually originates. Gets into the pterygopalatine fossa, which is a major crossroad for all these spaces around that area. And you can see how it's obstructing CSF, which is non-enhancing fluid, and cysts in the paranasal sinuses. So these are almost always supplied by internal maxillary artery from the external carotid, and you can see how vascular they are. We as interventional neurologists will often embolize them before the surgeons operate and take them out completely. A bonus case. This was a 15-year-old female with history of right-sided congenital Horner syndrome and intermittent mydriasis. And what is seen over here is always look for flow voids. This right flow void is missing. And if you look at her clinical picture, the color of the iris is different from one side to the other. So heterochromia is a well-known sign of ICA hyperplasia. And this symptom of intermittent mydriasis was because you can see that her PCOM was very hypertrophied, and this is the third nerve, this is the second nerve, and was compressing on the third nerve, causing pupillary symptoms. And you can see the hyperplasia of the ICA because there was no development of the petrous ICA. Just a last quick thing about hypertelorism, and this is something which, I get confused with. People have used different measurements, etc., but I think it all depends on context. So for example, if you look at Brad Pitt, handsome guy, but he looks hypotelluric to me. And then if you look at Angelina Jolie, beautiful female, but you can see she looks hypertelluric. But of course, both of them are completely normal individuals. So always make your diagnosis in the clinical context is very important. So with that, I thank you for your attention.
Thank you, sir, for showing those interesting cases and telling us the key points and highlights. It was really a good learning experience. So I think right now there are no questions in the chat box.
Right. Thank you, Mitusha. I'll be around if there are any more questions. Maybe we should move on. What do you think?
Yeah, sure, sir. So we can move to the next talk. And for this, we have with us Dr. Vivek Pai. Sir is pediatric neuroradiologist at Sick Kids Toronto, specialist in developmental brain disorders.